Sorry for the delay there.
Okay. Uh, didn't I bother you?
No, no, you're fine. Yeah, no, let's go ahead. Go ahead.
Okay, let me show you my questions. Do you see them?
Yes. Yep. Got him.
Okay, so that's the only questions that I managed to ask. So
Sure.
we have a very conservative approach at my center for the patients with Fontan. I read the paper written by you and colleagues
Mhm.
about direct oral anticoagulations using in patients in with Fontaine, and I want to ask about how do you define what patient exactly will receive uh, new oral anticoagulation and which one will receive the BK or aspirin maybe.
Sure. Yeah. So, I mean, I know that many centers obviously differ on their approaches. And so, a while ago, like many years ago, we had adopted that we would do warfarin for 3 months, plus or minus aspirin, and then aspirin after that. So we did warfarin, we did vitamin K antagonist for many years, and we would just do it for 3 months. And it was just sort of the time that we thought to endothelialize, and so that's kind of what we went with. Um, and then about, I'd say now, maybe probably about like 5 years ago or so, we switched over, and now all of our Fontans, regardless, all of them, we now do 3 months of apixaban or Eliquis, and then plus or minus aspirin, and then switch over to aspirin uh, thereafter.
It doesn't differ from the, I mean, like lateral tunnel or extracardiac conduit. It's every Fontaine at Boston.
Yep, every Fontan in Boston is going to leave on apixaban at least for 3 months.
Uh,
Um,
as I know, most of the fountains in Boston are fenestrated. The surgeons,
most of them, yeah,
so
yeah,
it
most
also
of them.
it doesn't depend on the presence of the fenestration or not. Okay,
Nope,
and
nope.
I also saw that the results was um, like the similar. It was the similar for the patients like in warfarin. So there is no very big benefits and there is no very poor outcomes. I mean, like in where when you're trying to compare these two groups.
Yeah, definitely. I mean, yeah, there weren't big differences between them. I think just from purely just from a quality of life standpoint, that was the only big difference, right? So obviously not having to test, INRs or anything, that kind of was the biggest selling point. And so yeah, so that's kind of our go-to now for all of our Fontans, regardless, is to do a Pixaban. We
So
chose a Pixaban. So out of all the DOACs, we chose a Pixaban. Somewhat biased. I kind of think that that is the best of the DOACs that are currently available. But we looked at like rivaroxaban or Xarelto because that was the what was it? The Universe trial, I think, that looked at comparing aspirin to rivaroxaban just in Fontan patients. And I believe they were on it for like an entire year, actually. So it was either rivaroxaban versus apixaban. And I don't recall the exact statistics from the study, but I know that it did well. And so that we had thought about that, but what we do that's kind of unique is that we do check anti-10A levels basically for the DOACs. It's an anti-10A level that's assayed specifically to the drug itself. So there's like an apixaban level, if you will, and a rivaroxaban level. And we looked
it
at like the adult literature to figure out the range, and then from that kind of extrapolated where we thought kids should land. And what we've discovered is that with the rivaroxaban dosing, it's underdosed. It doesn't actually target what we kind of would think to be as therapeutic levels. So therefore, it requires higher dosing than what's currently kind of recommended. And so that's kind of one of the reasons that we didn't go with that drug. But the apixaban, we started using it kind of pre-pandemic as part of a study and saw the benefits of it and used it thereafter. And now we probably have well over 1,000 patients, cardiac patients, that are on apixaban. We do have, and for
All of
different ranges.
are all of them Fontaine patients, or it's a various group?
Varies, right? So I don't know how many Fontans total we have on apixaban, to be honest, but just broadly, there's been, we've had probably now over 1,000 children, whether they just needed sort of prophylaxis or we were treating the clot or like our Kawasaki's disease. We use Fontan in our bioprosthetic valves. So we do like 3 months of apixaban in our bioprosthetic valves. So we use it frequently. And obviously it has its benefits for
Only 3 months of apixaban and no longer?
For the bioprosthetic valves.
Yeah.
That is debatable. Initially we said 3 months, but I think what we're seeing is that we're having better longevity if we keep them on it for longer. So we're kind of re-looking at that. But at the moment, our tentative plans are 3 months for our bioprosthetic valves.
Yeah, we used to use 6 months of VKA for the bioprosthetic valves, and then switch them to the aspirin. And what is the range of the anti-10A
The
level?
anti-10A range? Yeah. So, we kind of extrapolated this based off of what the adult range is. So for apixaban, we target like a therapeutic level, if you will, of 100 to 300. And I think it's in nanograms per ml. So it reports it as a concentration, but it is reflective of the anti-10A activity. And then if it's like a high risk scenario, so we have like our Kawasaki's patients, for example, on apixaban, then we target them higher, kind of in like the 200 to 300 range. And if it's truly just prophylaxis, like similar to like, let's just say just DVT type prophylaxis, like in a patient that maybe has a line in or something, we might target them lower, so more on like the 60 to 150 range.
And how long do you keep them on apixaban if this is a post cath like a post IV line thrombosis?
We'll start at 6 weeks. And
6 weeks.
and that's 6 weeks, yeah. So generally we'll do 6 weeks and then re-image, and then if the clot's still there, then we'll do like the full 3 months of treatment. But generally we do 6 weeks for true treatment, clot treatment.
And then you assess the patient again by the ultrasound?
Say that again?
I mean, like after 6 weeks of the treatment, you assess the patient's veins
By
again
ultrasound.
by the ultrasound, yeah?
Yep, exactly.
If the thrombus did not resolve completely,
Then we would do a full 3 months in total of treatment.
more 3 months, 3 months more.
3 months in total. So another
In
6
total,
weeks.
another 6 weeks, yeah.
Mhm.
Okay, I get it.
I don't know about you, but we see a lot of line related clots.
Okay. I mean, if the patient undergoing Fontan will have another indications for the VK, I mean, like a mechanical valve. So
Yep.
it's the only option when the Fontan patient will receive VKA in Boston.
So no, if it were a Fontan patient that also had a mechanical valve, they would get a VKA. That would be sort of our exclusion, if you will.
And this is the only one. I mean, like the only case when the patient will receive VKA. Or I mean, like if the patient have a significant history of thrombosis or like a IgA femoral thrombosis.
No, I think we would still. I think we would still lean towards doing a DOAC. I think we would still lean towards apixaban. I think the really only time I might say that we're going to do VKA is if there's a mechanical valve.
Okay. And why did you choose this uh, strategy? I mean, like, have you faced many of the VKA adverse effects, or why?
Um,
Or just keeping the quality of life better?
yeah, yeah, really just keeping quality of life better. I mean, I think that VKAs are much harder in that like 2 to 4 year range. Um, our TTRs were okay, like our time in therapeutic range on VKAs were all right, but certainly it requires more testing and yeah, so it's much more quality of life, I think, for us. It was kind of the determining factor to try something different and just switch over. Um, and so we tried really hard, like during the pandemic is really when we tried because we started I don't know if you know the saxophone trial that was looking at.
I read about the saxophone trial at your paper, and I will examine this paper later. Uh,
Yeah. So we were one of the initial centers to enroll patients in that saxophone trial, and it was basically just looking at um, clot prevention in cardiac conditions. And it was very broad, but we started using it like pre-pandemic and saw a lot of good results with it. And so during the pandemic, we tried to do our best to switch people over because then I mean we had some families that were fortunate and had like home testing devices
yeah.
to test their INR at home, but many didn't. And so many had to go to the lab and no one wanted to leave their house.
Okay.
So
Okay.
so we kind of started using it sort of outside of the box, if you will.
So
Um,
the environment pushed you.
yeah, exactly. Yes, for sure. Yep.
Yeah. Okay.
Yeah. And then, but then we've had success. So, I mean, we've looked at our event rates, and our event rates are definitely lower with our DOACs across the board compared to BKAs. And then bleeding is about the same, I think. There's not huge differences. It's kind of about the same. So for us, it just made sense. It was the kind of the smart move and the easier move. And I mean, for our levels, we would check them like our Fontanes, we would check them twice, kind of like a week apart once they started. And then honestly, that was it because we only left them on it for 3 months. So we wouldn't check them again. So they just had to take the medicine. So definitely a much better quality of life move.
Yeah, and maybe VK associated fatal bleedings are also very hazardous. I mean, like I know that you have adnexanet alpha as a
Yes.
antagonist to the apixaban, and
Yes.
it's but we have no.
Yeah.
Uh,
But honestly, though, I don't think that we would actually use it. Um, it's it is it will bind to anything that had any anti-10A drug, basically. And so if we have someone that's coming in and emergently needs surgery and it's going to go on bypass and needs heparin, it's going to make the heparin ineffective. And so if like for example, like we have some of our um transplant list, like our heart failure kids that are listed for transplant, if you will,
mhm.
that are on apixaban, and we have our procedures that if they get an offer, as soon as we know, we try to like obviously stop their anticoagulation, so we try to stop their apixaban, but sometimes we don't get enough time per se, and so we'll try to hold at least one dose, but um, basically we'll get a level probably about 4 to 6 hours before they're going to actually go to the OR, and then based off of that level, then we'll kind of decide if we need to reverse them or not. And if we're going to reverse them, we're actually going to reverse them with Kcentra, so the prothrombin complex concentrate for warfarin. Do you guys
Ah,
have that?
how did you call it?
We call it Kcentra. Like it's literally K and then Centra. That's the brand name, but it's a uh, thro prothrombin complex concentrate, and it basically has the 4 factors in it
Yeah,
that
I think we have
cause
a
warfarin.
Cargill. Like I think it should be Cargill. Yeah.
Okay, yeah, I know. Yeah, I know it comes in different brands. But yeah, so yeah, it's an activated like prothrombin complex thing.
Yeah,
The four factors.
it's a second, seventh, ninth, and tenth.
Yes. Yep.
Yeah, yeah,
Exactly. Yes.
yeah, yeah.
Yep. So we have
Yeah,
that, and so if we need to,
we
we use
have,
that.
but it names differently. But we
Okay.
have, yeah.
Yeah.
It
So
can
if
be
we
used
ever,
it can be used to reduce the bleeding from the VK also.
mhm, yep,
Oh,
we've
okay,
used it. It
that's
does
nice.
work. Yeah. So we usually use just like a straight flat dose for it. Like it's like 25 units per kilo. It's just a straight dose, and it works.
But we will increase the clotting of the mechanical valve. So yeah,
Right. Yeah. Yeah. We try
it's
not to use
it's a
any.
balance.
Yeah. We try not to
Yeah,
reverse unless we really have to. But yeah. But yeah,
yeah.
I think that at least what I've read in the adult literature with the andexanet alpha is that it has a very high thrombotic risk on the flip side of it. And so it doesn't, I don't think we would
It can
necessarily use
also.
it unless it was like life-threatening, legit life-threatening bleeding.
You said that it can also reduce the effectiveness of the heparin during
Yes.
bypass.
Yeah.
Wow.
Yep. Exactly. So it doesn't make sense to use it really because most kids, if they're bleeding that, if something that bad happened,
Yeah,
I
yeah.
feel that they're going to be needing some intervention. So,
Okay, so we complete first three questions. So we can go
yeah, did
directly
we?
to the fourth. No, yeah, but yeah,
Okay.
you already
Yeah.
answered to all of this. Yeah, and the last one is I mean like how do you manage the patients with primary? I mean like who was never diagnosed before
Hmm.
and came to the ED with the symptoms of PE or symptoms of deep venous thrombosis, and they underwent CT, chest CT, and they found in a non-severe but pulmonary embolism. How
Hmm.
will you manage them?
So those patients, I think we would use bivalrudin. So
Oh,
so right because a direct thrombin inhibitor. It has some clot lysing properties, if you will. So it can bind to thrombin in clots and not just like the circulating. And so we we would likely start them on that. Just because heparin, I don't know how your takes on it, but I don't like it. It's too difficult. No one can get it right. It's just too hard, I think, in pediatrics. And so,
yeah, I mean, like heparin itself cannot dissolve the
correct,
uh, already formed clot.
correct. Yeah, it's just going to
And
prevent it. It's going to prevent
is
it from
there
growing.
any cases? Are there any cases when you will use thrombolytics?
Yeah. So um if it's in an accessible spot where we think we can get in and maybe do some catheter directed, like TPA basically, then yes, sometimes that is certainly a possibility.
So
Um,
you are using only directed thrombolysis, like injection
yeah,
of the drug through the cath,
mhm. Yeah, it's
no
very
and no systemic thrombolysis.
not systemic. No, it's very rare that we use it systemically. Maybe like I mean maybe a stroke patient, but I think our go-to, our first line, if you will, is going to be bivalrudin.
Well,
Just because
okay,
we
okay,
can't slice that clot in any shape or fashion. Granted, then
okay.
you do worry about it showering off, um, and depositing elsewhere. But I think, and if we can't do, yeah, like if we can't do a catheter-directed TPA, then likely we're going to put the patient on bivalrudin.
Okay. Oh, we have no bioval or rush
Mm.
in Russia, yeah. So we have
Yeah.
only uh, thrombolytics.
Okay. So then, what do you guys do? Do you
Uh,
do systemic?
we if we feel confidently that the patient will not develop any severe bleeding, I mean, like
Mm-hmm.
if the one has no any history of the strokes and other medical history is well,
Mm-hmm.
so we'll try systemic thrombolysis,
Hmm.
and we success with it. I mean, like we try to um, um, monitor them with the fibrinogen level, try
Yep.
to refresh it if the
Yeah.
patient needs. Yeah. So we dissolve, I mean, like we had 5 to 6 cases last 5 years. Not so much,
Okay.
but we are
Yeah.
not so big medical center,
Hmm.
and most of them was most of them were successful. I
Okay.
mean,
Okay.
we used systemic thrombolysis in the patient with Fontan and protein-losing enteropathy who develop complete obstruction of the left lung. I mean, like
Oh
of the
wow.
left pulmonary artery, yeah, and it was successful. The patient is still alive.
Good. Okay. Good.
Uh,
That well, that's good to know. It's good to know. We generally have shied away from it, but it's good to know that you've had
yeah, yeah.
success.
You have another options less
It does, yeah.
less harmful to the patient.
Yeah, yeah, we're lucky. We do have some good options.
Yeah.
Um, so yeah,
Okay. Thank you very much. Thank
of
you.
course. Yeah,
If
you're
I
very
have
welcome.
some questions, can I type to you?
Yeah, for sure. Yeah, definitely. Feel free to. That sounds good.
Okay. Thank you.
Yeah. And if
Thank you
I
very
can't
much,
answer
Dr.
them, I
Harris.
can, yeah. But yeah, yeah, feel free to send any questions. And if I by chance if I'm not able to answer, I can certainly get someone that could. So let me
Okay.
know.
Okay. Thank you very much. Bye.
All right. You're
Have a good
welcome.
day.
Bye.
Bye.
You too. Bye.